Hello there. I'm really happy to be here. Thank you, Elise, for including me. So we're going to talk about the male side of the equation, and I'm going to be talking about some truths, and we will allude to the hero. I have no disclosures except for our private practice. And I want to start out with a man that I was introduced to. Actually, his work was introduced to me many years ago by a patient. And that man is Joseph Campbell. I don't know if you're aware of him, but he's a professor, a 20th century professor who researched to a great extent mythology and religion around the world. And he was a prolific writer, and this is one of his publications. And the summary of his research is this hero's journey. And so I'm going to allude to this during the talk. As you can see, you have several challenges in achieving the hero's journey. And in my opinion, the first thing is to explore and find the truth, and then to have the courage to uphold the truth. The truth will set us free, but as Gloria Steinem said, at first it will piss you off. So that brings me to the first truth, and that is, this is not prostatitis. And when I presented this little drawing at an NIH meeting with all the prostatitis experts of the world, they indeed got very pissed. I just said, the prostate's being blamed for all of this, and it's really not the problem. And it actually, initially, I thought it was going to destroy my career. Is it even urological? I think many of you in the room already know the differential diagnosis, and Dr. Day already gave a really wonderful summary of it. But in men, some things that may be a little more specific are the outlet obstruction issues, and they are a little more prone to stricture disease. Bladder neck hyperplasia can occur. That can occur in women too, by the way, because that's not the prostate. Urinary calculus, especially in the UVJ. Infections, sometimes people really do have a genuine infection, an STI, and then maybe 5% of the patients labeled as prostatitis could indeed have a prostatic infection. And orchitis can occur as well. Neoplasm can play a role. Metastatic lesions can cause pain and are often missed. And ischemic conditions such as testicular torsion or an organ infarct. But generally speaking, here's another hard truth. It's really not even urological. We know that most patients who present, if you look at the data from Ken Peters and Rob Maldwin, about 75% of patients presenting with pelvic pain have myofascial disorders, maybe some connective tissue contributors. But I later found that 65% have functional somatic syndromes, or what today are called central sensitization syndromes. And that's not 65% of the remaining, it's 65% of the cohort. So obviously they're overlapping. And overlapping together with that are different types of neuropathic pain, psychosocial issues, some infectious diseases, and again, those same urological diagnoses. So just because there's a myofascial trigger point there, it doesn't exclude the possibility that they have a genuine urological or even a surgically solvable condition. Even patients with metastatic cancer can have myofascial trigger points. So we have to take the time to understand our patients, and I love what Dr. Day said. Just, let the patient speak. Let them give the story, because you really don't have to know everything. You just have to listen and know what doesn't make sense in the history and in the physical examination. All it takes is active listening to understand the patient's work, the patient's lifestyle, the patient's commute to work, things of such. The sexual history is of greatest importance, I believe. We get a picture into the patient's relationships, stressors. We need to know about arousal, erection, and even more common than erectile dysfunction is ejaculatory dysfunction. So we need to make a comfortable setting and have an interview with respect to this facet of a man's life. And it's not enough to just document in the review of systems that this man has a normal bowel movement every day and there's no blood. We need to understand what that process feels like. We need to understand if the patient feels satisfied and evacuated completely after having a bowel movement. And we often include a Bristol score during our evaluation. What does the man do on his free time, or what does he do to stay fit? We have to understand what that is. It helps to somewhat have sports interest yourself and try to be a little bit of a jock so that you can walk the walk and talk the talk because you'll understand the patients better. Are they using good technique? In my practice, I tend to see two different sides of the spectrum. The patient with shortened muscles who is weak and sedentary, sits a lot. And then I have, especially in California, the extreme athlete with super strong muscles, but shortened ones nevertheless. So that brings us to truth number 3, and that there are no shortcuts. You can see this hero's journey, you have to do the whole cycle. You can't just skip across. And it's the same when interviewing patients and even doing the physical examination. Never take a shortcut, and if necessary, just schedule another appointment. On the hero's journey, the first thing that comes up is having a mentor. And this was my mentor. In the mid-1990s, Dr. Kirsch, a urologist at the Cleveland Clinic, said to me, you know what, I think that the prostatitis thing is a bunch of garbage, and I think you should consider trying physical therapy for it. So that's what I did. I studied physical therapy. I put myself through physical therapy so I could learn how to do these assessments. And in doing so, I explored other issues outside of urology: discogenic pain, spinal pain, orthopedic issues. You'd be surprised how an orthotic can really solve orcalgia and spare a man from having his testicle removed for pain. Myofascial trigger points. We learn to detect those taut bands and those knots. It's so easy when the body has two sides. You can teach yourself these things by comparing the different parts of the body. You have the two sides to compare. And you learn that there's weakness in the affected area. The joints that are affected will demonstrate a diminished range of motion. And sometimes we even are rewarded with referred pain and a twitch response. And this really helps to corroborate the diagnosis. And here is an example of the psoas muscle in yellow. So that's the culpable site with its predicted pain referral pattern. And these are things you just start watching for: the patient's walk, their gait, how they sit, how they stand. Here are the adductor muscles. And I usually like to assess these like in a splayed manner, but you can also do these with the person lying supine. This is my favorite muscle to assess, the obturator internus, and that's done internally with some provocative testing. And here's just an example of the piriformis, but as many of you know, there are many, many more, and you just have to methodically inspect them. This is a view of the right hemipelvis from the inside, showing the course of the pudendal nerve. And you can see how the different branches innervate the perianal area, the perineum, the scrotum, and the penis. It's very rewarding, likewise, to gently palpate that area of Alcock's canal, reproduce some of the discomfort, and have the patient help you corroborate the diagnosis. This is often a confusable diagnosis. This is impingement of the posterior femoral cutaneous nerve, so it's important to keep that in mind too. It's not meant to burden the patient with an additional diagnosis, because oftentimes the same therapy you will be using will help improve this as well. But it's very important to understand, when there's especially sitting pain, that the pudendal nerve is not the only culpable part. This is how I do all of my physical examinations on men in the lithotomy position. I use my right hand to examine the right hemipelvis and my left to do the left. I check the coccyx here for mobility. There should be a 1 to 2 centimeter mobilization without any pain. The obturator, and lastly, as part of the exam, I palpate the prostate gland. I want to teach the patient that it is normal to have a sensitive prostate gland, and also for him to learn that there are other components of the pelvis that are contributing to the pain. And that's very rewarding, and it really conjures a lot more trust. And I have to say that every time I hear, after 25 years of explaining this, demonstrating this, it still upsets me to know that most patients only receive a half-assed exam, as we say in English, because they're just bent over and they have their prostate checked. So it's not a good exam, it's a half-assed exam. The fourth truth is that PT has become the new Cipro, because that examination is not done. And what do I mean by this? This is not a good thing. PT, physical therapy, is being prescribed with the same level of disregard that ciprofloxacin has been prescribed for decades, without evidence, without an exam, without a culture, without follow-up. This is a patient with 5 years of diverticulitis, acute and chronic. Physical therapy was never going to help this. Here's a patient with a chondrosarcoma of the acetabulum, a 36-year-old who needed to have a hemipulvectomy. Physical therapy was not going to help that. And here's a patient that I had in my office recently, a young man. This is an ultrasound I did. He's got a thickened bladder wall, and he's got hydroureters, hydronephrosis. Fortunately, we diagnosed this before it led to renal failure. This is his cystoscopic exam with retroflexion. That is bladder neck hyperplasia. That is the worst case I've ever seen. And as I said before, this is not the prostate. Women can get this too. This is the bladder neck. This person had 20 years of problems, 6 urologists, urodynamics, and cystoscopy, and was referred to physical therapy. He went to 5 different ones before he finally decided, I'm going to kill myself, or because I don't get it, or get another opinion. This brings me to truth number 5. Functional somatic syndromes and central sensitization is very common in urologic chronic pelvic pain. In this part of my hero's journey, I received a magical gift. This was from Dr. Leonard Calabrese. He's the chair of rheumatology at the Cleveland Clinic. And the gift he gave me was this article by Wesley et al. In The Lancet, which changed my career. Functional somatic syndromes in the article are defined as a constellation of symptoms which are frequently persistent and distressing, which after appropriate medical assessment cannot be explained in terms of a conventionally defined medical disease. When I looked at the list in the article, I realized that prostatitis was missing and that it should be included there. As you can see on this list, there is a disease or diagnosis in every medical or surgical subspecialty, and each one of these represent at least 30% of outpatient consultations. So I immediately did a review of 100 consecutive cases. And I found that 65% of my patients who were seeking second opinion back in 2000 for prostatitis met the criteria for a functional somatic syndrome. And this is really compelling when the population lifetime prevalence is only 4%. So here again, we're not dealing with a urological condition, we're dealing with a global systemic problem. Shortly thereafter, a group of the Prostatitis Network took the database and compared the chronic prostatitis patients with control and found that a significantly higher number of the men reported comorbidities and symptoms in all of these domains. Again, consistent with people suffering with overlapping syndromes. In about 2006-2007, Mohammed Yunus renamed this as central sensitization syndrome, which was a much better name. And in this schematic, you can see the predisposing factors that we all encounter when we're interviewing our patients, how it sets up this cascading effect to lead to central sensitization. And very importantly, you can see here it's a two-way street. Once this central sensitization has taken hold, it now sensitizes the whole organism, and it creates this vicious cycle. Dr. Yunus is also responsible, by the way, for changing the name of fibromyositis to fibromyalgia. More recently, the NIH-sponsored MAP studies are corroborating what we have already known. The pain mapping studies have shown that 75% of patients have pain outside of the pelvis. Again, we're not dealing with a purely urological condition. Many of the patients have sleep disturbances, and as the sleep disturbance prevalence increases, so do the non-urological conditions and vice versa. The high rate of depression is greatly associated with the centralization phenomenon, and the patients have been shown to exhibit poor illness coping and helplessness, as we've seen illustrated by the work of Dean Tripp and Curtis Nickel. So on this road of trials and tests, on this hero journey, now we need to ask about the definition of central sensitization syndrome. Is the taxonomy appropriate? Are we going to be dealing with different subtypes, phenotypes of this syndrome? And I think that Dr. Arkoff is going to help us answer these questions. Finally, along the hero's journey, You often need to be rescued. And in 1998, Dr. Rodney Anderson, who is now retired from Stanford, was my rescuer, because back then when I was young and on this journey and scared and having my reputation being called into question, he said to me from across the country, "You're okay, you're not crazy, don't worry, and you're not alone." So I'd like to end with this video, and I'd like you to place yourself into the role, and hopefully this will be inspiring to you, and also after you take this journey, you will then help your patients take a similar journey.